So you're going to look amazing right afterwards. You, however, will look like a water balloon. So when I said you're going to look amazing, that was kind of an overstatement. Hi, so I really wanted to sit down and share with everyone some of the key points that I find a lot of patients are asking about during their mommy makeover consultations. So I have brought in our practice manager, Fotini, who is a real expert in this, having gone through many of these conversations with me, so that she and I can kind of talk through a consultation and make sure we share what we think is important, and we invite you to ask any questions that you might have in the comments. Welcome, Fotini.
Hi, everyone. So happy to be here and happy to go over all of these different types of procedures that constitute a mommy makeover and go over the questions that patients ask us every day during these consultations.
So I think one of the first things to talk about is, what is a mommy makeover? And the answer is, a mommy makeover actually is not a type of surgery. It's a marketing term. And a mommy makeover can really be anything that you want it to be to help restore your body back to its pre-pregnancy condition. And generally speaking, the abdomen and the breasts are the two body areas that tend to be most affected by pregnancy and breastfeeding. So it's not surprising that those are the two areas that are most frequently involved in mommy makeover surgery. Specifically with respect to the abdomen, when someone is pregnant, their uterus expands. To make room for the expanding uterus, the two rectus muscles, the six-pack muscles, can separate from each other in the midline. That leads to what's called a rectus diastasis. That's a weakening in the connective tissue between the rectus muscles. That's not the same thing as a true hernia, which is when there's an actual hole in the connective tissue. And that's a much more complex anatomical problem that really is pretty unusual in the context of a mommy makeover. So for the purposes of this conversation, the most common thing that we're addressing with an abdominoplasty in the context of pregnancy is a rectus diastasis. We address that by identifying the two medial or central edges of the rectus muscles and sewing them back together. And that has a few important effects. First is functional. You might have noticed that since pregnancy, your core strength just isn't what it used to be. You might see that in the gym. You also might even have some urge incontinence or some stress incontinence. Even that can be affected by things like the tone of your core and your rectus muscle anatomy. The last thing is back pain. People find that having an abdominoplasty is a surprising way to actually address back pain, because when you fix your core muscles, you're really kind of rebalancing everything and restoring the balance that your body was supposed to have in the first place.
Not all mommy makeovers are created equal. We also have patients coming in that don't necessarily have a large diastasis, or they're not looking to repair it. That way, they ask, am I a candidate for a mini tummy tuck? Or similarly, am I a candidate for just a reverse abdominoplasty? What's the difference between all of these procedures?
There are a million different kinds of abdominoplasty, and on top of the fact that there are differences, surgeons tend to brand them and give them fancy names, so you really can't tell what's going on. At its core, an abdominoplasty, a full abdominoplasty, is an operation that's designed to treat the three primary anatomical layers of the abdomen. Starting on the inside, that's the abdominal wall. Then there's the subcutaneous or superficial fats over the abdominal wall, and then there's the skin that's over that. In a full abdominoplasty, like we just mentioned, we're addressing that rectus diastasis. We're often doing some liposuction to contour the fat in the abdominal region. And then we're also doing some skin excision. And that's why with a full abdominoplasty, there's a lengthy scar that generally goes from hip to hip. It's hidden under the underwear line. There's also a scar at the belly button. We're really good at hiding it within the belly button, so that the result is you can actually wear a bikini and walk down the beach and no one should know that you had surgery. So that's the full tummy tuck. A mini tummy tuck or mini abdominoplasty is a great operation for the right patient. It is certainly a less invasive procedure. It has a shorter recovery, but it's more limited in its scope. So a mini tummy tuck is very good potentially for a patient who has skin excess and maybe some fat excess just in the area from below their belly button to above the mons. For that region, a mini tummy tuck can be very effective. Where it falls short, though, is in two important places. One, generally speaking, it's very difficult to effectively perform a rectus muscle plication through a mini tummy tuck. So if you're someone that has a rectus diastasis that you're looking to treat, a mini tummy tuck probably isn't the way to go. It's also not very good at treating skin laxity that's over the belly button, so kind of between the bottom of your breast and your belly button. If you have loose, rippled skin there, a mini tummy tuck isn't going to do that. And conceptually, it makes sense because when we do a full abdominoplasty, which very effectively addresses laxity all the way down from the xiphoid process down to the mons area, the reason you're putting an incision around the belly button is because you need to lift up the skin flap so that you can work in that area. If you're not releasing the belly button from the surrounding skin and you try to just pull down from below like you might in a mini tummy tuck, you can imagine that not much is going to happen to the skin and soft tissue above the belly button. The kind of least common variation of this is a reverse abdominoplasty. So while a mini tummy tuck or a mini abdominoplasty is very effective for people that just have laxity below the belly button, the reverse abdominoplasty does the opposite. It can be a great option for someone who doesn't have a rectus diastasis. They don't have much laxity below the belly button, but they do have a laxity that they'd like to address above the belly button. And the way this operation works is we hide the incision, we hide the scar in the folds under the breast. And this works very well, especially if someone has more pendulous breasts. The scar is really very nicely hidden. We can address that upper abdominal laxity, and you avoid having surgery or scarring by your belly button. And you also avoid the long, low scar of a traditional abdominoplasty.
In all of these procedures, if you currently have a C-section scar, do you replace it with the abdominoplasty scar, or do you now have two scars in the pubic region?
So the C-section scar, a modern C-section scar, tends to be a very low scar, which is great. When we do our tummy tucks, we can pretty much always make our scar even lower. And since with a tummy tuck, a full abdominoplasty, you're removing all of the skin between the belly button and that mons pubis below, the C-section scar comes with it. So you're effectively replacing the C-section scar with an abdominoplasty scar.
Another question a lot of patients ask is, why are there certain practices that use drains during a tummy tuck and some that promote the drainless or the tubeless tummy tuck? What is the difference, and why is it so important to use drains or not to?
So classically, when the abdominoplasty was developed, it was an operation that is done with drains, which raises a question, why are we using drains in surgery at all? So if you've ever gotten a blister, you've noticed that as your body heals the blister, there's often fluid in a bubble. And that's simply because as part of the inflammatory process, as part of the healing process, your body naturally makes fluid. An abdominoplasty is no different. When you raise that abdominal skin flap and do the work, when you do the rectus plication, when you do some liposuction, you're creating inflammation, and you're also leaving behind what's called a dead space, an empty space between the abdominoplasty flap that you've raised off of the abdominal wall and the abdominal wall itself. The body does not like empty spaces, and it tends to fill them with fluid, just like in a blister. Your body can very effectively manage a certain degree of that fluid and reabsorb it on its own. For larger fluid amounts, for when we're predicting that your body's going to make a significant amount of fluid, the body might outstrip its own ability to reabsorb that fluid. In those cases, we like to use drains to help get rid of the extra fluid. Why can't you leave fluid sitting there? A couple reasons. One, it's a great way to get an infection. If you leave fluid sitting around in a warm environment, bacteria love that. So we don't want to be too friendly to them. Also, if you leave fluid sitting around, which is called a seroma, that seroma over time can actually develop a rind or a connective tissue shelf, which can cause contour deformities and ruin the aesthetic result of your operation. So the default in abdominoplasty is to use drains to prevent fluid collections. Now, it's very reasonable in some cases to perform a drainless abdominoplasty. This tends to be a good idea in patients that won't necessarily have as much dead space as part of their operation, or if we're incorporating a technology called progressive tension sutures, where we're closing down that dead space as we're going along. And in certain cases, I will offer this. However, in the majority of cases, I find that the risk-benefit ratio really favors using drains to minimize the chances of having a seroma at all costs. Because, yes, drains are annoying, and I'm honestly willing to annoy you for a couple of weeks so that you don't go on to develop a seroma, which can cause serious problems like an infection, like contour abnormalities, and require repeated visits to our office to drain that seroma. So it's definitely kind of slick and more convenient to do an abdominoplasty without drains, and for the right patients, I'm happy to do it. But when you look at the majority of all comers, you're going to be better served by using drains and avoiding those complications.
Thank you for that. Another question obviously patients are concerned about is pain management and how things have come such a long way from the abdominoplasties and breast lifts of 10 years ago and how we currently manage pain now to get patients ambulated quickly and recovering safely.
So that has been one of the most remarkable advances in aesthetic plastic surgery, the management of pain after these procedures. So classically, after a tummy tuck, patients would assume that they'd be in a lot of pain. They'd envision themselves barely able to walk around or even being bedridden. And nothing could be further from the truth today. I'm not going to sit here and tell you that a tummy tuck and a mommy makeover is not significant surgery. It absolutely is. You need to plan accordingly for it, and that's the subject of another video. But the amount of acute pain that you are going to have after a tummy tuck today is dramatically diminished compared to what it was 10 years ago. And there are several reasons for that. First is we're using more and more advanced multimodal pain regimens, often either minimizing or avoiding narcotics altogether to help you feel comfortable and get you up out of bed quickly. And this isn't only for your comfort, but when you're up and out of bed quickly, your complication rate goes way down. So we are going to do everything in our power to help you be mobile. I don't want you lying around in bed. I want you up, walking around right away. And the way that we do this actually starts before your surgery. The night before your procedure, I'm going to have you start taking a medication called Drainless. This is a relatively new medication. It's a very powerful pain receptor blocker. It works a lot like an opioid works, but it only affects the pain receptors. You don't get the drowsiness or the drunk feeling or any of the addictive tendencies that you get with opioids. You also don't get the constipation that often comes with opioids. So it's a very clean drug. It's a sodium channel blocker. It actually is the same mechanism as vocal anesthetic in a lot of ways. So that is kind of a game changer. It sets the tone for a more comfortable recovery. The next thing we do is at the time of surgery, we actually take a very targeted approach to managing the source of your pain. There is no question that that thing that hurts in a tummy tuck is a rectus muscle fixation. Whenever we operate on muscle, it hurts. Muscle is very highly vascular tissue. It has a lot of blood vessels. It has a lot of nerves. So when you manipulate it, the patient isn't happy. To address this, we use an injectable long-acting pain medication called Exparel. We lay it right into the rectus muscles and into your incisions at the time of surgery. This is a medication that's comprised of a liposomal bupivacaine. So it's a pain medication that's actually coated in a tiny microsphere that gradually degrades over the days after surgery. So it dramatically reduces the discomfort that you have for the first 2 to 3 days after your operation. By the time the Exparel wears off, you're over that acute pain hump. And at that point, you're really just feeling soreness. So between the Drainless, kind of dialing down the background level of pain, and the Exparel directly targeting that acute pain, you're going to be way ahead of the game. And the truth is that even just by being up and mobile, you're going to be treating your pain yourself by preventing yourself from just becoming essentially trapped in bed and stiff and uncomfortable from that perspective. Also, by using these two medications, we can minimize or even sometimes eliminate the use of narcotics, which is great for a lot of reasons, not least of which is if we can prevent constipation, that's a whole other source of discomfort that you definitely don't want to be dealing with.
Perfect. Now let's segue into the other major operation usually involved in a mommy makeover. We're talking about breast surgery, whether it's augmentation, breast lift with implant, breast lift with fat transfer, all the different types of operations, auto augmentation being another way we can add volume, and what you recommend for who, and just a little bit about these procedures.
So, yes, breast surgery is tremendously powerful, and it comes in many different varieties. And there are essentially three ways that we can address the breasts. We can make them larger, we can make them smaller, and we can change their position or, more frequently lift them. And we can do combinations of those things. The right operation depends on the patient's anatomy and her goals. For a patient that, especially if she's breastfed, there is often loss of volume. There's often loss of volume after breastfeeding, and this can lead to a very classic deflated upper pole appearance. It can also lead to ptosis or drooping, and this is a condition that is very effectively treated with a breast lift, and there are several different kinds of breast lifts that we can get into in a different video. But when we talk about a breast lift, it's important to remember that it will not address a volume deficit. If you don't like the fact that you lost some volume from your breast during pregnancy or breastfeeding, a breast lift itself will not address that. In fact, a breast lift by default will actually make your breasts a little bit smaller. And the reason is that part of a breast lift involves removing extra skin. So if you have a certain breast tissue volume and it's droopy or codic, and you go and tighten the skin around it, you're shrinking everything. So even if your breast weighs the exact same amount it did before and after a breast lift, when you go and actually do that operation, the breast is going to look and feel appreciably smaller in a lot of cases. So an isolated breast lift can be a really good option, but you have to make sure that you understand the ramifications of choosing that path. On the other hand, if you're someone whose breasts aren't that tonic or aren't really drooping after pregnancy and breastfeeding, but they maybe lost some volume, a breast augmentation can be a great approach. However, a breast augmentation, a breast implant, is not going to provide a significant amount of lift. It is a real error to try to lift a nipple or an areola by more than about a centimeter at the absolute maximum by doing a breast augmentation alone. If you have volume loss and you also have some ptosis that you'd like to address, a combination breast augmentation mastopexy is the way to go. That addresses both the size and the shape of the breast very effectively. Fotini asked about something called an auto-augmentation. A breast auto-augmentation is a really fascinating concept that we've been using more and more with great success. This is an operation, and it's great in the context of the postpartum period, where someone has lost volume from their breast. They have tissue laxity, and the volume they do have is kind of redistributed to places they don't want it. Specifically, the volume has kind of moved from the upper pole with like a perky appearance to the lower pole with a more of a sagging appearance. So what we're doing with an auto-augmentation, in addition to doing the kind of skin and soft tissue rearrangement that we're always doing with a breast lift, we're actually using your existing breast tissue as an implant and placing that tissue in such a way that we're restoring upper pole fullness without an implant. So there is a very well-defined group of patients for whom this is a good option. And if it's something you're interested in, we should definitely discuss it during your consultation. We just talked about using an auto-augmentation, or we can even use a fat transfer to do a breast augmentation. And this can be a good option for someone who wants a moderate to small increase in breast size. And generally, a half a cup to a cup is a reasonable expectation for the kind of increase in breast volume that you can expect with a fat transfer-based breast augmentation. There are several things that go into determining if you're a good candidate for this. First and foremost, do you have enough of your own fat to use? Next, what is the skin envelope like of your breasts? If you have very tight breast skin and you try to do a fat transfer, the pressure involved is going to create a very hostile environment for those cells that you've essentially transplanted into the area. And that's an important thing to recognize about breast fat transfer in general. You're literally doing a cell transplant. So you're taking cells, fat cells, from one part of the body, often the abdomen or in the waist. You're disconnecting them from their blood supply, and you're transporting them to another part of the body. It's like, okay, now I want you to live over here. And for the first little while, 24 to 48 hours, those cells are literally just floating in fluid. They're soaking in nutrients from the fluid around them. They don't have a blood supply. And what we need to do is take every measure we can to enhance their ability to attract and grow a new blood supply over time. And over the period of 2 or 3 weeks, that happens through a process called angiogenesis. New blood vessels grow into the area, and they can robustly supply those transferred fat cells with nutrients and provide them with an egress for waste products, just like any other cell or tissue in your body. So again, fat transfer, very powerful approach, but you need to be the right patient.
For both of these procedures, when do you think is the best time to schedule? Like at your goal weight, or should I be within a certain amount of pounds from my goal weight, just to have like everlasting results and make sure you're doing it at the right time?
So super important consideration. When we're talking about timing a mommy makeover, we have to think about the patient's weight and also the patient's hormonal status. So on a very absolute level, we want our patients to be at their goal weight and stable at that weight for ideally 3 or even better is 6 months, because we don't want to operate on a moving target. When we're doing these operations, when we're doing a tummy tuck, when we're doing a breast lift, we are essentially tailoring your skin envelope to the volume of these different body areas. And if you do one of these operations and the volume of that body area significantly decreases, you're going to have recurrent laxity. So to save you the recovery, the expenditure, and just the whole process of going through a mommy makeover, it's really best to wait until 3 to 6 months after you've been stable at your goal weight. Similarly, pregnancy and breastfeeding, it's not a surprise, causes major hormonal changes. Those hormonal changes can actually change the distribution of fat in your body. It takes 3 to 6 months for those circulating hormones to leave the body after pregnancy and breastfeeding, and for your body to return to a steady state of kind of fat distribution. For both weight stability reasons and hormone stability reasons, 3 to 6 months is really the ideal amount of time I like to wait before I'll perform a mommy makeover type of procedure. And just to be clear, if you're not breastfeeding, we can do it 3 to 6 months after delivery. If you are breastfeeding, it should be 3 to 6 months after you've stopped breastfeeding, because just breastfeeding itself promotes this kind of different hormonal milieu.
Amazing. Thank you so much. Another question patients frequently ask is, especially if they do have children at home, the type of support they need to recover from these surgeries, whether it's how many hours or days should they have nursing care, or how long until a loved one can efficiently take care of them. What do you recommend is the best form of plan for recovery?
Yeah, I mean, that's so important and something that is so easily overlooked. And the best way to make this easy is to plan, from everything to taking time off from work, making sure you have childcare, making sure the items around the house that you need easy access to aren't on a high up shelf. In terms of the exact recovery, the truth is it's different for everyone, but there are some reasonable expectations that I would set. For the first 2 or 3 days, you will be up walking around, but you won't be doing much more than that. And for the first week, you're going to be walking a bit bent over because everything is so tight after a tummy tuck. So I would really plan on having significant help available for everything from cooking to showering to really taking care of yourself for 2 or 3 days. Days 3 to 7, you start to become more independent. You might be making small meals for yourself, really just kind of putting things in the microwave or making a sandwich. By about a week, you're going to be, getting back into the swing of things. I tell my patients that can work remotely, they generally feel comfortable doing so by 7 days after surgery. It's really at about 2 weeks when things are more or less back to normal in terms of functionality. You're still going to be sore, you're still going to know you had surgery, but you can absolutely get back to an office setting at that point. Specifically with respect to childcare, it depends a lot on the age and behavior of your child, but I really like my patients to plan on a good 2 weeks where they're not lifting up their kids. So if that's something that you can arrange for your partner or a parent to help you with, that's a really good move as well.
So lastly, I do think it's very important. So a lot of our patients understand that they are training in their shape for scar. So they know, for me to get this shape, I need to have this scar. And just to give the rundown of when a scar is considered fully mature, when can it have its maximum fade, how soon can you intervene with lasers or scar treatments, and just what to expect from a scar perspective.
Scars are a necessary part of these procedures. And you're exactly right. We're trading shape for scar. And scars in general start out red, and they can be thick, and they're usually kind of at their worst from weeks 4 to 6, and then they begin to improve. While we often say that they have kind of done their most improvement by about a year or out to 2 years, scars really continue to mature for the rest of your life. So it's a reasonable expectation that by really a year or so, you'll be pretty happy with the way your scars look. There are lots of things we can do along the way to accelerate that process and also to improve the final outcome. And this ranges from different laser treatments, from CO2 for things like texture, to brown and darker pigments, to pulse dye lasers for reds and pink pigments. And a lot of these lasers can actually be started pretty early. Data is showing that if you're starting as early as about 2 weeks, that can be very impactful. We also make aggressive use of silicone sheeting. I like to have my patients wear silicone sheets on their scars for the first year after the procedure, and that causes significant improvement in scar quality. The one exception to that is by the belly button. I find that a silicone-based scar gel is much more effective in that region, just because if you try to put silicone tape there, things just kind of moist and gross. We shouldn't end up moist and gross.
A lot of our patients come from all over the world, and especially when they call us an out-of-town patient, they ask, how long do I need to stay in town for a procedure like this? How does it work for out-of-town patients?
Right. So this is something that we encounter daily. And again, it comes down to planning. First, I like my patients that are coming from far away, especially from overseas, to really arrive in town 2 days before their procedure. And that's not just for convenience, it's also a safety thing, because one of the risks of any of these larger operations is a venous thromboembolism, or a blood clot that starts in your legs, goes to your lungs, and can be very dangerous. And one of the best ways to prevent that is to be mobile. So if you've just gotten off a 9-hour flight and walk into the operating room, you're setting yourself up for a problem. If you can get here 48 hours in advance, walk around the city a little bit, Bergdorf's is 2 blocks that way, that's good for safety too. The other thing is, I don't want you to be dehydrated. That's also a way to increase the risk of complications. So you should get here 2 days before, get the lay of the land, we'll meet in person, and just do things in a comfortable way. In terms of recovering from the procedure, if I could have my absolute dream, I would have you here for 2 weeks after surgery. And I know that's almost never possible. And the reason I say 2 weeks is because these drains that we use, one comes out at about a week, the next one comes out at about 2 weeks. So if you're able to stay here until both of your drains are out, that's just easier. However, that almost never is the case. So I like my patients to stay here at least until their first drain is out, and then we can make arrangements with your local provider to remove that drain for you at home. Which brings up another point. If you're going to be traveling to me for surgery, I'm going to be certain that I have connections wherever you're from to make sure that you have continuity of care. We're going to be seeing you virtually quite frequently, but I want to make sure that if you need to be seen in person, there's someone on standby that I can rely on to help you.
And the most important question of them all, I feel, is when are my results final? When do I get to enjoy my new body and not have to deal with any more recovery?
Yeah, so you're going to look amazing right afterwards. You're going to look totally different. Your breasts are going to be perkier and volumized, and you know, you're going to have that right away. The extra skin on your abdomen is going to be gone. You, however, will look like a water balloon. So when I said you're going to look amazing, that was kind of an overstatement, because I can kind of see through the swelling. But when you look in the mirror, you're going to be a little, you'll like the shapes of your breasts, but otherwise you're going to be pretty swollen. And it honestly takes maybe a month for most of that swelling to go down to the point that you're going to be pretty pleased with your appearance. It really takes about 3 months for, I'd say, 70% of your results to come in, and really a full year for the full results to become apparent. But it's worth it, and our patients really just love this procedure.